Okay, a 21-year-old man comes to the student healthcare service because of 6 month history of increasingly frequent episodes of moderate chest pain. Uh, the first episode occurs while he was sitting in the traffic feeling stressed. Mm, he was late for the he was late for college. At that time he had sudden onset moderate chest pain and rapid heartbeat, nausea. He says he felt as though he were going to die. The episode lasted approximately 10 minutes. He had similar episode 1 month ago while he was on TED. He says that he says he fears having episode in public or on TED. So he has decreased in participation in social activities. He has no history of serious illness, take no medication, vital signs are normal, physical examination no harm. She has anxious mood, full range of effect. Which of the following is the most likely diagnosis? Ready? It is
Yeah.
agoraphobia.
Um, it's not this one. What is the explanation? Okay, it's agoraphobia. I have two things for explanation, so I don't know. But this one is not in order. I don't think so. Okay, I use this one. Agoraphobia, the most number of sentences in the question dedicated to describing agoraphobia where the person is afraid of being outside. It is not D. I was between D. Get anxious in wait. I think I was yeah, I was D. Get anxious in social situation where they have to speak to someone, present, otherwise they are fine. A person in the question had a single one situation where they were in a social situation Okay, I just kinda I guess I'll go with that explanation. Here is not in order. Let me see. Okay, I guess we'll time to find it like that. This patient sudden intense fear of somatic symptoms and somatic symptoms such as rapid heartbeat, sweating, which lasts for a short duration, are characteristic of panic attack. But USMLE understand that when patients start avoiding places and situations due to fear of these attacks, it become agoraphobia. Oh, hmm. He avoids social activity and spending time outside, fearing another attack, which indicates agoraphobia. That's the key. Panic attacks are acute episodes of intense fear, while agoraphobia is the avoidance behavior stemming from the fear of having an attack in a situation where escape might be difficult. When encountering USMLE question describing a patient with panic attack who avoids situation due to fear of recurrence, go towards agoraphobia. And it's not social anxiety, it's intense fear of social situations where others might scrutinize one. Okay, that's a good thing to know. Next.
Yes. If a 35-year-old man is brought to the ED by his friend 30 minutes after the sudden onset right-sided weakness and difficulty speaking. The symptoms begin while he was lifting weights at the gym. He has not had headache or changes in vision. He has no history of serious illness, takes no medication. He does not smoke cigarettes or drink alcohol. He exercises regularly. His speech is coherent, but he can understand what others are saying. Vital signs are within normal limit. No blue or heart over the carotid artery. Cardiopulmonary examination shows no abnormality. There is swelling, mild tenderness of the right lower extremity. No cords are palpated. Neurologic examination shows right-sided facial drop and right upper extremity weakness. MRI of the brain shows acute stroke in the left middle cerebral artery territory. Carried ultrasonography shows no abnormal. Which of the following is the most appropriate?
Ready?
Still ready?
Yeah. So it is echo with bubble study. Patient mostly has patent foramen ovale that led to an emboli traveling from the right side of the heart to the left side of the heart. Okay, person had a stroke, but there are elements that. Okay, so I think this is explanation from Divine. Person had a stroke, but there are elements that do not sound like a classic presentation. This person does not have the RF for stroke, does not have the RF of a stroke patient. So what's going on? When people have strokes, either carotid problem or cardiac issue. However, the carotid problems are ruled out from the lineage. The patient had a DVT that led to a stroke. That links DVT to a stroke. Cardiac anomaly, pattern foramen ovale or BST, where the person had embolism that led to this. And it's now cardiac MRI with gadolinium. Very, very rarely the answer choice. Will the MRI if worried about a type of infiltrative disease of the heart? Makes sense. Okay. You want me to find the other explanation or that one is fine?
CT
Um,
angiography.
okay. This it just says this will be for PE. I
Oh,
can find the explanation here. It's just that these ones are not in order. I have to type it. Okay. So here city and geography. Never mind, it's kind of like the same thing as the other one. Uh, wait. Yeah, it's kind of the same explanation as the other one. Yeah, there's no more. City and geo, it just says it's for PE.
okay.
Yeah. Next.
A 65-year-old man comes to the office because of 2 year history of progressive shortness of breath and exertion, 6 month history of non-productive cough. He has now shortness of breath when walking to his mailbox. He has not had fever, weight loss, or chest pain. He has not had recent sick contacts, has had no occupational exposure, and own by does not own any pets. He has difficult to control atrial fibrillation, hypertension, COPD, migraines. Medications are amiodarone, warfarin, lisinopril, tiotropium, propanol. Temperature is 47 pulse 80 per minute. Irregular respiration. Blood pressure 110 by 70. There is no jugular venous distension. Auscultation of the lung discloses fine crackles bilaterally both anteriorly and posteriorly but no egophony. The remainder of the physical examination discloses no crackles but both anteriorly and posteriorly. The remainder of the physical examination no abnormality. An adverse effect of which of the following medication is most likely cause? He has only non-productive cough.
Mhm.
Ready?
Yes. So the answer here is amiodarone. Uh, what exactly are we treating? Question starts. There are AFib, and patient is one drug that is indicated for AFib that could be cause pulmonary fibrosis. That's A, amiodarone. Pulmonary fibrosis can be caused by bleomycin, busulfan, amiodarone, and methotrexate. Um, you want me to find the other
No.
explanation? No, okay.
An 18-month-old girl is brought to the emergency department by his mother 30 minutes after he fell from his bed onto the floor. 2 months ago, he sustained a fracture of his right humerus when he fell while playing onto the park. The fracture healed quickly with immobilization and casting. His mother sustained several Her mother sustained several bone fractures in the early childhood, but she currently does not have any medical concern. On arrival, the baby is crying. Pulse is 162 per minute, respiration 48 per minute, blood pressure 122 by 80 millimeter of mercury. Examination discloses bluish sclera, ecchymosis, and tenderness over the right tibia. X-ray of the right lower extremity confirms a fracture of the tibia. The right lower extremity is immobilized with a cast. Limitation of the physical activity is recommended to prevent Limitation of the physical activity is recommended to prevent a future fracture. Given this patient's condition, it is most appropriate for which of the following type of screening done regularly. Ready? Is it osteogenesis imperfecta?
I think so, but I forgot what were the complications of it. Wait, no. Okay, this one. Yeah, this one. Osteogenesis imperfecta doesn't make sense to pick something with a low cardiac. Also, doesn't make sense to pick something with a low cardiac. And surgery that relates mainly to pathology cannot hydroxylate lysine residues, so they cannot make procollagen. Language delay, most likely mechanism, conductive hearing loss, dysfunction of middle ear ossicles. So it's audiography, type 1 collagen issue in bone, teeth, skin, eye, and ear. Tiny bone in the ear can be easily affected. They have conductive hearing loss. Okay. Um, I don't know if here they will say something different. Okay. Say the child recurrent fractures with minimal trauma and bluish clear osteogenitis imperfecta, collagen synthesis disorder. One of the common complications of us is sensory neural hearing loss, often beginning in early childhood and adolescence. Regular audiography is recommended to detect managed hearing loss in early in patients. Osteogenesis is hereditary disorder with key features including increased bone fragility, bluish sclera, and hearing loss. When presented with pediatric patients with recurrent fractures and blue sclera, yeah, in clinical scenarios always correlate the findings to no complications of the described condition. Okay, guess next.
Yes. A 70-year-old yes, a 70-year-old woman is admitted uh, to the hospital because of 1 hour history of shortness of breath. 1 hour history of shortness of breath. She has lung cancer and dementia, Alzheimer type. She has lung cancer, dementia, Alzheimer type, and has a decline in mental status. She lives with her boyfriend 20 years. He has cared for her and has taken care. He has cared for her and has taken care of home since she was diagnosed dementia 2 years ago. She has one adult son who lives out state, but she speaks to him phone daily. The patient's neighbor, who is a nurse, long-term plan. The patient is unable to understand the poor prognosis of her condition. She has not designated healthcare power of attorney. Which of the following is the most appropriate person to make medical decision for this patient?
Ready?
Wait 1 second.
Okay.
Ready.
Okay, so it's the adult son, and there is not another explanation for that. Um, okay, I cannot find it on this one. But do you
Sorry.
want me to? Do you want me to? You good, or you want me to find it on this one?
No, no, no.
Okay, okay,
Let's move forward.
okay.
It is as she is staying with her boyfriend. She does not have the power to take decisions.
Yeah, because he's not her husband.
Sorry.
No, because he's not. You mean the boyfriend doesn't have? What are you asking? The boyfriend doesn't have. Is that
Like
what you ask?
yes, yes.
Because
So
she's
according to US law, the boyfriend has not that decision making capacity, even if he is staying with her.
no, because it's not the husband. It's not her husband.
Okay.
They are not married. Mhm. I cannot find it on now. Okay, next.
A 4 month old female A 4 month old female is recovering in the hospital 5 days after uncomplicated surgical repair of VSD via median sternotomy utilizing cardiopulmonary bypass. She has extubated on postoperative day 1, and by the postoperative day 4, she has no longer receiving any inotropic infusions or IV drugs. She is breastfeeding well. Plans are made for discharge from the hospital the next morning. However, the next morning she develops temperature 101.8 degree Fahrenheit, cool, calm skin, cold distal extremities, delayed capillary refill, and minimal urine output. Cardiac rhythm strip and tracing of arterial blood pressure are shown. Which of the following is the most appropriate next step in evaluation?
Ready?
Yes.
Oops, sorry, wrong one. It is echo, and the EKG shows a narrow. Let me see. Oh, that was the answer. There are close friends and boyfriend, but who has unique? Never mind. That's not a good answer. Never mind. The EKG, sorry. The EKG shows a narrow complex tachycardia. Person had cardiac surgery a few days ago. Now, after some time delayed, some type of shock. Yes, yeah. A lot of choices should be focusing on heart. Cardiac MRI are rarely the correct answer. Stuck between two. So much of the question is dedicated to heart function. A simple test is probably the better option since it can be done quick. Okay. Oh, what was the other answer choices? Uh, 4 month old. Never mind. I cannot find it. 4 month old female. Maybe. Right here. Okay. The infant presentation of acute decompensation with symptoms like cold, extremities, the leg appear event, decreased urinary output after cardiac surgery, suggests a cardiac cause, most likely related to the surgery. Echo is not invasive, readily available and rapid modality to evaluate cardiac function, valvular issues, and potential pericardial effusion and tamponade. For USMLE echo is often the first diagnostic step when suspecting a complication from cardiac surgery in a pediatric patient. Mm, Postoperative cardiac issues in children, especially after procedures like VSD, can present with signs of poor perfusion and cardiac output. Be prepared to rapidly evaluate cardiac function in a postoperative setting using the most direct and non-invasive means available. Okay. Want me to read another answer?
No.
Okay.
Age 6 years, birth, female, ethnicity, unspecified, emergency. My daughter's eyes and legs are swollen. 2 week history of calf congestion. 2 week history of calf congestion and runny nose. That seems to be improving. Parents reports Parents report the patient's eyes seemed swollen 4 days ago, which they initially attributed to the patient's cold. 2 day history of swelling over the top of her feet. This morning she was unable to put her on shoes because her feet were too swollen. Past medical history, unremarkable medication, none, vaccination up to date, no history of allergy, family history, mother's age 30 years, father's age 32 years, twin sisters and 10 years, and alive, no contraindication. Physical examination, temperature normal, pulse 140, respiration 20, BP 120 by 70, oxygen saturation 99%, BMI 19, my 19, appearance mildly, skin 2 plus pitting edema on both extremity up to knees, uh, periorbital edema, no erythema, parla, ocular movement are intact, clear to auscultation, cardiac, no murmurs, RBC 5 to 10, high power field, RBC 5 to 10, high power field. Which of the following additional lab findings are most likely? Which of the following additional lab findings are most likely to be decreased in this patient? Decrease.
Be decreased. Hmm. Hmm. Yes,
Ready?
sure. Which one is more different? It is B, serum albumin concentration. Um, Upper respiratory infection and edema, some type of nephrotic syndrome, more protein for nephrotic, low, low complement proteins in the setting of for streptococcal pneumonitis in the presentation of a nephritic syndrome acquired 3 plus blood on urinalysis. Uh, Serum albumin concentration is low because they're peeing out proteins or decrease oncotic pressure. Um, I don't know if you want me to read the other. Let me see. Serum albumin concentration. Okay, here. The patient's presentation of periorbital edema like edema, proteinuria, suggests nephrotic syndrome, commonly associated with hypoalbuminemia. Nephrotic syndrome is characterized by massive proteinuria, hypoalbumin, edema, and hyperlipidemia. For USME, understand that decreased serum albumin in nephrotic syndrome leads to decreased oncotic pressure and edema. Nephrotic syndrome in children often present with puffiness around the eye and swelling in the legs and ankles. Link the clinical features of edema with pathophysiology of the decreased albumin leading to reduced oncotic pressure. Remember that in children, minimal change disease is the most common cause of nephrotic syndrome and is characterized by low albumin without significant inflammation or hematuria. It's not serum C3, C4, decreased complement levels are seen in nephritic syndrome. Okay, next.
Yes. A 9-year-old girl is brought to the clinic for a routine examination. She has 4-year history of asthma. Her only medication is inhaled albuterol with a spacer as needed. She uses it only occasionally and has not used it at all during the past 4 weeks. Her father reports that her father reports that the his daughter had episodes of coughing that awakens her at night once weekly. He also says that his daughter has sedentary lifestyle because she coughs if she runs too much. No one in the family smokes cigarettes and there are no pets. Gas heaters are used in the home. The patient is at 25 percentile for height, 90 percentile for weight, and BMI. Respirations are 16 per minute. Lungs are clear to auscultation. There is no clubbing in this digit. The remainder of the examination show no abnormal. Which of the following is the most appropriate next step in the management? Okay.
Okay, so the answer is add fluticasone by method dose inhaler with a spacer to the regimen. This kiddo has asthma. She sometimes uses albuterol. She has symptoms once a week. Since she's having symptoms, go to the next step. They don't bother with categorization. What is better is to break it down. B2 agonist first. If there is no control of symptoms, add a steroid. If still not, then a salmeterol. Salmeterol is what, like a long acting?
Yes. Yes.
Okay,
Long-acting beta agonist
okay. And then Montelukast. Montelukast is
is leukotriene receptor antagonist.
okay. And then oral steroid. So short acting, inhale short acting, inhale steroids, inhale long acting, oral steroids. Okay. Did he say anything else? No, he did not say anything else. Let's look at this one.
Is this
Fluticasone.
the divine Explanation.
This one is the divine explanation. This one.
Okay.
This one is, I don't know, you sent me this one. I don't know which one is. This child displays features of quality control asthma evidenced by nighttime coughing. Yeah. The USMLE expects students to recognize that adding a daily inhaled steroid like fluticasone is primary step in long-term asthma control. Nighttime coughing and activity limitation are two hallmarks of poor asthma control. And inhaled steroid is indicated when symptoms occur more than twice daily. No, sorry, more than twice a week or cause nighttime awakening more than twice a month. And it's not salmeterol or long-acting, not be used alone in asthma due to severe exacerbation risk. Always combined with a steroid. Oh, that's why you give steroid first. Okay. Next.
A 30-year-old man A 30-year-old man comes to the office to establish primary care. Medical history is unremarkable, and he takes no medication. His wife had myocardial infarction at age 48 hours. The patient has smoked one half of cigarettes daily for 10 years. He does not drink alcoholic beverages. He is 168 centimeter tall. He is 168 centimeter tall, weight is 82 kg by 29 kg per meter square. Vital signs are within normal limits. The patient is not in distress. Physical examination discloses no abnormality. Smoking cessation is recommended. Which of the following is the most appropriate screening for this patient at this time? Ready?
Yes. So is fasting serum lipid study. Patient is obese. Wait, is he? Oh, I guess 29 is obese. So he needs some type of screening. C and D are essentially out. A are not necessarily good for screening unless you are looking for a test. Always look for a more common factor, as in if this patient is obese, then they most likely have a lipid problem. Okay, let's see. What's that? Maybe this one. Nope. Fasting serum lipids. Never mind. I cannot find in here. Fasting serum lipid studies. Lipids studies. Never mind. I cannot find it. Oh, right here. Sorry. Yeah. The patient has family history of premature cardiovascular disease, with his father having an MI 48. Assessing and managing this epidemic is crucial for the primary prevention of cardiovascular disease in high-risk individuals. For USME, remember that individuals with a family history of premature heart disease and personal risk factor like smoking should undergo lipid screening to assess this epidemic. Patients with family history of early heart disease are at increased risk. Early screening for modifiable factors is cornerstone of prevention. Always relate the patient risk factors to the most appropriate preventing strategy. The relationship between lipids and cardiovascular risk is central here. No screening studies are indicated. Given the patient family history, blah, blah, yeah, that's why you have to do the screening. So because the dad died of cardiovascular and he is smoking. Okay, next.
An 82-year-old an 82-year-old man comes to the office because of 1 month history of increasing numbness. on her feet, increasing numbness on her feet. She has no history of serious illness. She has no history of serious illness. She has taken over the counter calcium carbonate tablet for intermittent abdominal pain during the past 40 years. She takes no other medication. She has drunk 2 glasses of wine with dinner nightly for 50 years. On examination, gastrocnemius, deep tendon. On examination, gastrocnemius, deep tendon reflex are absent. White Babinski sign is absent bilaterally. Light touch. Babinski sign is absent bilaterally. Light touch to the distal lower extremities and feet produce a tingling sensation. Sensation to vibration over the great toes is severely decreased. There is a mild to moderate decrease in proprioception of the great toes. Which of the following is the most likely to prevent progression of these neurologic findings?
Okay, so next supplementation. She drinks 2 glasses of wine.
Ready?
One moment. Calcium carbonate. Maybe calcium carbonate cessation. Okay, ready. Ready. Sorry. Um, it is. I don't know what it is, but okay. Uh, wait, what is the answer? It's vitamin B12 supplementation. Dorsal column, light touch and proprioception. Don't overthink it, just speak F and move right along. Subaqueous combined generation, dorsal column, and possibly a lateral column lending to some upper motor neuron
Does
symptoms.
alcohol cause vitamin B12 or folate deficiency?
Mm, Both?
Sorry,
Wait, I don't know. Both? Or is it folate?
I
I
as
don't
far I
know.
remember, it is folate deficiency, isn't it?
Yeah, but it seems like here she doesn't really have alcohol issues. Wait, alcohol cessation. Yeah, it's probably not helping, but it won't prevent.
Is
Okay, I guess.
calcium carbonate can cause vitamin B12 deficiency?
I thought so. That's why I picked that. I thought, but I guess not. Calcium carbonate cessation not going to prevent neurologic. Yeah, I guess no, it doesn't. It doesn't. What was my other thing? Alcohol. It says yeah, yeah, she drinks, but um, it won't prevent the neurologic symptoms that she has. And folic acid sulfate has no neuropathic association. Yeah, it just causes anemia. So yeah, I guess the answer is for vitamin B12 supplementation. Oh, what is the other one? Never mind. Let me see that one if that one has B12. Oh, no, it's not that one.
Just copy
Uh,
the first two, three point of the question.
yeah, sometimes it doesn't come out. You see, I try to do it for the other one. Like I don't know. I rather just look at the answer, search the answer. I don't know. Sometimes the Anyway, uh, the patient's symptoms: numbness, absent tendon, deep tendon reflexes, decreased vibration, proprioception, indicate peripheral neuropathy, and given the prolonged intake of calcium carbonate, B12 malabsorption is suggested. Okay, this is what I thought. This is what he said. Okay, it's due to her calcium carbonate that she has B12 deficiency. So I thought if we stop the calcium carbonate, then she won't have B12 malabsorption. That's why I picked them. Anyway, for USMLE, calcium can bind to B12 in the stomach, leading to decreased absorption and deficiency. Peripheral neuropathy with sensory deficits combined with a history of prolonged calcium carbonate intake should raise suspicion of B12 deficiency. Always assess for dietary and medication history, which may influence B12. It's not calcium satiation. Chronic alcohol use can cause neuropathy and cerebellar and gait abnormalities. Okay, fine. Calcium carbonate cessation may reduce the B12 depletion, but will not replace already depleted stores. Oh, okay. Okay, I get what they're saying. Okay, got it. Next.
Yes, a 50-year-old a 50-year-old man comes to the office for a health 50-year-old man comes to the office for a health maintenance examination. He says he has felt well and reports no symptoms. Medical history is unremarkable. He takes no medication. He uses up to 3 cans of chewing tobacco weekly and occasionally sleeps with tobacco in his mouth. He says he would like to quit but cannot seem to do it uh, on his own. Vital signs are within normal limit. Examination shows whitish discoloration that measures approximately 1 centimeter in diameter on the buccal mucosa. The tongue has a reddish brownish. The tongue has a brownish discoloration. Palpation of the neck discloses on lymphadenopathy. In addition to encouraging the patient, sorry. In addition, where I am, examination show whitish discoloration measures approximately 1 centimeter in diameter of the buccal mucosa. The tongue has brownish discoloration. Palpation of the neck shows lymphadenopathy. In addition to encouraging the patient to quit using chewing tobacco, which of the following is the most appropriate next step in the management?
Ready?
Ready.
So it is surgical biopsy of the oral lesion. This is essentially suspicious for being precancerous, similar to lichen sclerosis of the vulva. Biopsy to rule out squamous cell carcinoma. Um, the patient's long-term use of chewing tobacco and white lesion on the mouth are worrisome for leukoplakia or premalignant lesion. Surgical biopsy is definitive diagnosis. Step to evaluate for dysplasia or carcinoma in this lesion. USMLE recognized that smokeless tobacco users are increases of developing oral cancer, precancerous lesion like leukoplakia. A chronic white non-scrapable lesion in a smokeless tobacco user should raise concern for leukoplakia, oral cancer. To assess associated risks, always take a throughout tobacco history, including smokeless tobacco. Okay. Next.
A 48-year-old man is brought to the emergency department by ambulance 45 minutes after he collapsed at home. He did not have loss of consciousness. He has a 6-week history of shortness of breath and severe fatigue when he walks 20 to 30 feet during the past 6 weeks. He also has had a 5 kg weight gain despite a decreased appetite. He has no history of serious illness. He cannot remember his last visit to a physician. His only medication is ibuprofen for intermittent and mild headache. His father died of heart problems at the age of 78 years. The patient has smoked one pack of cigarettes daily for 22 years. He has consumed 24 cans of beer weekly for 20 years. Um, he works as a painting and drywall contractor but was unable to work last week because of fatigue. Temperature is 36.8, pulse 100 per minute regular, respiration 16 per minute, blood pressure 90 by 50 while supine. 90 by 50 while supine. Pulse oximeter 4 liter per minute of oxygen by nasal canal and shows an oxygen saturation 91%. On examination, crackles are heard halfway up the lungs bilaterally, and S3 is heard, and S3 is heard. No murmurs are heard. The liver span is 5 centimeters. There is moderate pitting edema of the calves and ankle swelling bilaterally. Echocardiography is most likely to show which of the following findings.
Ready?
Echocardiography. Wait 1 second, please.
Okay.
Okay.
Okay, so it's dilated cardiomyopathy. Patient has smoked and drank a lot of alcohol. Hypoxic, has S3, is related to having systolic dysfunction, likely dilated left ventricle. Patient has heart failure. Why dilated? Because he's frequent alcohol drinker, thiamine deficiency, wet beriberi, thiamine pyruvate, hydrogen complex dysfunction. Can run out of thiamine in about like 17 weeks. Heart is essentially thiamine dependent because it needs ATP. Heart needs ATP to contract, so undergo systole. If the heart cannot contract, the volume will keep accumulating. This is eccentric series addition of sarcomere.
How she has like vitamin B1 deficiency.
She drinks a lot.
Lots of people drinks a lot.
Oh no, but she's been drink. She's. Are you wait? Are you bothering me or you just
No,
saying
no,
it for
no,
me?
no, no, no.
Okay, okay.
I'm
I
not.
don't know. I don't know if you're joking or you
No, no,
just
no.
saying it
I'm
for
not
me.
uh, talking about you. There, in my mind, there is nothing about you. I am just curious. Like lots of people is drinking a lot. Is lots of people have dilated cardiomyopathy? That's my question.
No, but it says she's been drinking a lot for 20 years.
24 cans a beer weekly. Weekly. Is it a
Weekly.
lot? I don't know
Yeah.
actually. I don't understand about this. That's why I'm asking. 24 cans of beer, is it a lot? In the
I
movies,
don't.
what I have seen that people are drinking lots, like people are drinking cans after cans and nothing happens. Like I always think about movies and all that things. That's why I'm asking. You got my point.
Yeah, yeah.
So is there any any calculation to think about, like if you take this kind of beer, or if you take this kind of thing for a prolonged period, then there is a chance of having DCM or other vitamin B1 deficiency, because alcohol is normal for Western people, isn't it? Lots of people alcohol take alcohol in on daily basis, but
Mhm.
DCM is a problem, isn't it?
Yes. Remember, there is that normal
Y-
amount of drink per
yes, there
day.
is something like that, 24 hours something written. Uh,
Ye- Yeah, there's no. I think for women, it's like if it's more than two per day, then it's a lot. And men, it's like if it's more than two. More men if it's more than one per day, then it's a lot. And men if it's more than two per
two
day, it's a lot.
glass, two
Two
glass.
glass. Yeah.
Okay.
So here for example, I don't know because the fact that they say can, there is small cans and there is big cans, so you cannot really know just
Yeah,
because they say can. But if you divide 24 cans a week
a
is 7
lot.
days. Yeah, 24 cans between 7 days is 3 cans per day.
Cans per day.
So that
Okay.
that is still already a lot. It's more than, obviously the can is more than a cup than a drink. So it's, yeah, it's still a lot for a man. It should be two, so now it's three, so it's still a lot. And then for 20 years, I think that's how I added that it's
And another confusing thing in here, that there is S3 is heart. S3 gallop is for heart failure.
yes, exactly, yeah.
So why the same? There, that is my another query.
You find S3 on DCM. Remember DCM, the hard is like floppy, so there is S3.
Yes.
Yeah,
Okay.
there
Okay.
is S3. There is S3. I was between that and
I was
what
between
did you say?
C.
C. I was between C because when they say ventricular hypertrophy, hypertrophy can be eccentric or concentric. So I didn't know if they meant like the concentric or I didn't know what they meant, but I guess this one makes more sense. The dilated cardiomyopathy. And I guess that, you know what? Instead of guessing, let me actually read. Let me instead of just guessing, let me read what they say. Left ventricular hypertrophy, we do not hear a S4. Okay, so they meant the concentric. We do not hear a S4 chronic pressure overload concentric addition in parallel to existing sarcomeres. Okay, so here they meant the concentric one. So the one that you see when you have a aortic stenosis kind of thing. That's the one that they
Okay.
meant. Yeah, yeah. I really didn't go with. I don't know how they correlated the the drinking with the thiamine with the heart. I didn't know all that. I just saw S3, and I was like, the only thing that has S3 here is the dilated. This one doesn't have. You already know this one. Pericardia doesn't have S3. The wall motion that he would have had a chest pain or whatever ischemic heart disease. So no. And paradoxical. What was this one again? Paradoxical septal motion. I forgot what was.
Paradoxical septal motion. Don't know.
It's is related to something.
HOCM. Is it related to HOCM?
Septal, maybe. Yeah, yeah. I
Just
guess.
okay.
Yeah,
Okay.
you're right.
Okay.
HCM. Yeah, yeah. I knew it's related to something. Yeah. So there is no S3 there, of course. So the only thing that we're making sense with, yeah, what's it related?
Okay. Next.
Mhm.
A 68-year-old man comes to the clinic because of 6-month history. 6-month history of frequent fall. He sustained a fracture of the left wrist 4 weeks ago during a fall. He has not had loss of consciousness before or during the falls. He says that turning and pivoting often cause him to fall and has a tendency to fall backward when walking. He has Parkinson's disease, treated with carbidopa levodopa and entacapone. Vital signs are within normal limit. Examination shows masked faces and a resting tremor of the right upper extremity. Romberg sign is absent when patient stands still is put back. When patient stands still and is pulled backward, he is unable to maintain his posture. Which of the following is the most appropriate intervention to decrease this patient's risk for future falls? Ready?
Yeah, it's physical therapy. Tendency to fall. What can be done to decrease risk? If there are three answer farm drugs, all are dopamine receptor agonists, you can help rule out those treatments. Biofeedback is like ethics committee answer, not very likely. Physical activity and therapy can help decrease the risk for falling Parkinson. I think that's physical therapy. Yeah, right, therapy good. No, yeah, sorry, therapy is with the thing. Never mind, I cannot find it here. So, okay, you said to copy. I cannot copy this. It's gonna delete my thing.
Okay, I
Uh,
found it.
okay.
Why the correct answer is right. Patients
Mhm.
with Parkinson's disease often develop postural instability characterized by impaired balance and a tendency to fall. This patient is experiencing postural instability. A crucial intervention for this patient is physical therapy, emphasizing balance training and exercise to improve gait. You want me to read the other options?
Yes, the CDE.
Okay. Pramipexole, a dopamine agonist, does not effectively help in postural instability and falling risk. Ropinirole, it is similar to pramipexole, it does not directly reduce the risk of fall due to postural instability, and rotigotinin, rotigotinin therapy dopamine agonist, no effect on postural instability in Parkinson patients.
Okay, perfect. Next.
A 6-year-old boy a 6-year-old boy is brought to the office by his parents as a new patient. 3 months ago, he and his 3-year-old sister and 4-year-old brother were adopted from Russian orphanage, where they have had lived for 2 years. Their biological parents died in a motor vehicle. Their biological parents died in a motor vehicle collision. The adoptive parents say that they were told the children has had and had stable caregivers, age appropriate simulation, school at the orphanage. The children were shy initially on meeting them, but now seem comfortable. They play well with each other. The patient is protective of his siblings. His medical and developmental history prior to 2 years ago is unknown. He has been learning English slowly. His parents hope he will learn enough by the end of the summer to begin kindergarten, a grade below that of his peers. Although he can perform basic mathematics, he is unable to read even Russian. Results of the repetitive language testing are consistent with an average IQ. His daily living skills are appropriate for age. He is at 10 percentile for height and weight. During the examination, the patient's adoptive mother, who is fluent in Russian, translates him. Physical examination show no abnormality. On mental status examination, he is shy. He is shy, maintains eye contact. He slowly answers questions with a brief statement. He smiles and says he is excited, pleased about being adopted. Results of the lab studies are within the reference. Which of the following is the most appropriate? Which of the following is the most likely diagnosis?
Ready?
Ready? Yes.
It is learning disorder. In one specific academic area, he's struggling. What do you think is going on? Not A. There are no fixations, so it's not autism. No evidence in regards to alcohol, so it's not fetal alcohol syndrome. And many struggles of domains, crawling and walking later than others, interactions are delayed, low IQ. So it's not C, it's not intellectual developmental disorder because he doesn't have like all of this. And let's see the other one. So the chart shows specific difficulties in reading, despite average IQ and age appropriate daily living skills. Characteristic of learning disorder. The USME expects students to recognize that learning disorder can manifest as specific academic challenges, even when a general intellectual ability is within normal limits. Um, can okay. A history of institutionalization can lead to various developmental issues. When there is a specific deficit like reading difficulty in the presence of normal intellectual functioning and appropriate daily living skills, think of learning disorders. Okay, next.
A 17-year-old boy is brought to the emergency department because of 1 hour history of progressive difficulty breathing. Because of 1 hour history of progressive difficulty breathing and 2 hour history of itchy red rash over the trunk, arms, and the legs. He has not used new soaps, detergents, or lotions during the past week. 36 years ago, he began a week course of amoxicillin for ear infection. He has taken 4 doses that. Since that time, he has no history of serious pulse 100, BP 90/60, pulse of 95%. He appears anxious in moderate respiratory distress. Is it anaphylaxis?
I think so.
Okay, epinephrine. Ready?
Okay, so it's administration of epilepsy. This person has an anaphylactic shock, drug of choice,
What you have
epinephrine.
said?
This person has an anaphylactic shock,
You said
drug of
epilepsy, isn't it?
oh,
Okay.
epinephrine. Sorry, it's administration of epinephrine. Sorry, did I say epilepsy? I don't know. So that, yeah, epinephrine. This patient has an anaphylactic shock, drug of choice, epinephrine, type 1 hypersensitivity. Okay, next. I think that one is
What
easy.
I do, I try to listen what you are saying and try to match your wordings with my answer.
Your
That's
word
why
with my answer. Like when I, like
when
when
you
I,
start reading,
the
like
answer,
the
okay,
yes,
okay.
yes. That's why okay, no problem.
Okay, I
That's
didn't
why
know.
when you just said the word, that strikes my ear.
Okay.
Okay, no problem. 2 weeks 2 weeks after undergoing open cholecystectomy for gangrenous cholecystitis, a 47-year-old woman comes to the clinic for removal of surgical taboo. She was treated with oral vancomycin for C. diff colitis during hospitalization. She has type 2 diabetes mellitus, current medication metformin, pantoprazole. She reports loose stool four times daily for the past 2 weeks. In addition to wearing a clean isolation, in addition to wearing a clean isolation gown, which of the following is the most appropriate precaution for the physician to take?
Ready?
1 minute.
Okay.
Ready.
So it is washing hands truly with soap and water. Healthcare systems sanitizer does not do anything for CDF. It's all about the soap and water. Same concept for rotavirus. Let me see if this is something here. Washing hands. CDF. Spores resist alcohol hand-based sanitizer. Patients with history of C. diff infection, especially recently, should prompt providers to wash hands with soap and water to remove spores physically. Hand hygiene with soap and water is preferred for C. diff when hands are visibly soiled. C. diff infection is associated with antibiotic use and results in diarrhea, often recurrent. Consider C. diff in postoperative patients with diarrhea, especially after antibiotic use. Focus on describing the patient's symptoms and recent history to recognize the red flag for C. diff. It's not a surgical mass. C. diff is not transmitted to respiratory droplets. It's not sterile gloves and correct. The concern is about C. diff transmission, not surgical site infection. Okay, and alcohol gel is not effective against the C. diff spores. Next,
Yes.
Jesus, a bit long one. Ugh. After this one, we need a break. Sorry. I hate those longest questions. Oh, God.
Okay. In patients with opioid use disorder, what is the relative efficacy of buprenorphine and methadone maintenance? Review scope included study compared to buprenorphine BMT buprenorphine maintenance therapy more than 1 milligram per day with methadone maintenance therapy and MT more than 20 milligram per day, or placebo including 1 milligram per day of buprenorphine in patients who were dependent on heroin or other opioids. Studies of pregnant women and those assessing buprenorphine or methadone for detoxification, but with no maintenance phase, were excluded. Outcomes include treatment retention and urinalysis confirmed use of methadone, cocaine, and benzodiazepine. Review method, Medline and Embase. What is this? Okay. Authors were consulted. 31 randomized control trial. N is 5430, ranging from 40 to 737, and made the selection criteria. Duration of this study intervention ranged from 2 weeks to 52 weeks. 20 trials compared with BMT with MMT, and 11 compared BMT with placebo. Main result, as shown in this table, below low, medium, and high dose BMT increased treatment retention more than placebo. BMT did not differ from equivalent doses of MMT for retention or had lower retention or had lower retention. High dose standard mean difference minus 1.17, 95% confidence interval minus 1.85 to minus 0.49, but no medium or low dose BMT decreased morphine used more than placebo, and medium and flexible dose BMT and MMT did not differ for morphine use and use of cocaine use. BMT or BMT versus MMT and high dose BMT versus placebo did not differ for benzodiazepine use. Okay, there is a huge box. Conclusion. In addition, in patients with opioid use disorder, buprenorphine is more efficacious than placebo, but less efficacious than maintenance methadone therapy for treatment retention. Source of funding structure is buprenorphine maintenance versus placebo or methadone maintenance for opioid dependence. Now, question. A 38-year-old woman comes to the clinic for follow-up examination. She has opioid use disorder and currently takes methadone 40 milligram daily as a maintenance therapy. She says the methadone is causing mild sedation that is interfering with her job. She would like to discontinue methadone. She would like to discontinue methadone maintenance therapy, but is concerned about heroin relapse. She says she also takes a friend's Valium when she is feeling stressed out. The physician discusses alternative maintenance therapy strategies with the patient. The physician discusses the pros and the cons of medium or high buprenorphine maintenance therapy compared with medium or high dose methadone therapy with the patient based on this abstract. Which of the following is the most appropriate information for the physician to convey to the patient?
Treatment. Okay. Okay. Someone significant. Okay, maybe. Then neither drug is more effective than placebo. Okay. BMT, case my opinion is more than placebo. Yeah. BMT is not dependent on neither drug is more effective than placebo. There is an unclear difference in efficacy between the two drugs at these doses. These doses. The physician is medium and high dose buprenorphine. Medium and high dose. Medium. Okay, what are they saying? There is unclear difference in efficacy between drugs at these doses. Hmm. Methadone is statistically more likely to result in treatment retention. Let's see if we have a methadone. Between C and E, unclear difference. There's a difference. There's no difference in efficacy. Okay, I guess I would choose C. Methadone is statistically more likely to result in treatment retention. I think that's what it says here, but mm, okay, okay. I have to pick one. Okay. Between C and E, there is unclear difference. Unclear. No, there is no there is no difference. Okay, okay. Ready?
Yes.
Wait, what did you pick?
Nothing.
Nothing.
I was very depressed when you
I
were
was like,
looking.
Jesus
Sir,
Christ, that's
that's why I stopped looking at.
okay. I'm between C and I feel like it's gonna be E, probably. It's E. Oh my God. Uh, where was that? Okay, that's 17. Yeah. Drug ad. Pay attention to exclusion criteria. Treatment retention. People that continue with the therapy. Look at morphine, cocaine, and benzos. High dose buprenorphine, methadone. The results were not significant compared to median. That's not significant. I don't know what that means. Relative risk reduction, which is um, 1 minus relative risk. Wherever the CI includes one, not is significant. Advice for biostat question, leave at the end of the block. Since they can be time consuming. That's definitely divine. He always says that in his thing. There is a clear difference in efficacy
But
between
at
the
the end
two.
of the block, we don't have any time. So what
They
will
don't
you
have
do?
any time. That's the thing. But anyway, let me see this. He didn't really explain anything here. Let me see. Maybe buprenorphine. Okay, so there is unclear difference in efficacy between the two drugs. Buprenorphine and methadone are both effective opioid agonist treatment for opioid use disorder. Studies have shown variability in outcomes, and there is no clear-cut advantage um, of one over the other in terms of efficacy at medium and high dose. For USMLE, it's crucial to recognize that both drugs have proven benefits, but head-to-head comparisons at different doses do not demonstrate consistent winner in efficacy. Both buprenorphine and methadone are mainstay treatment for opioid use disorder with their side effect profiles and considerations. Differentiate between the two based on on side effects, drug interaction, and patient preference rather than absolute efficacy. Remember the dangers of combining opioids with benzo due to risk of respiratory depression. It's not C. Both methadone and buprenorphine have shown benefits in treatment retention, and neither is universally superior. Okay, next.
Which of the following aspects of the study is most likely to limit confidence in the author's conclusion? Which of the following aspects of this study is most likely to limit confidence?
Jesus.
I think that this question is better to leave than to waste my time.
What if it comes on the exam? The analysis treatment retention. Did they use the analysis for treatment retention? Confirm the morphine, cocaine, the benzo. No, really, they didn't.
These questions are very tentative. If you understand, you will get 3 out of 3. If you don't, you will get 3 out of 0.
No, sometimes you can get one out of three. Okay, let's just pick one. Sometimes you
Okay,
can
let's see. Let's see your
get,
observation.
sometimes you can get one. Inclusion, you see, at least I got one.
Okay,
Inclusion of trials with an intervention duration of 2 weeks. It doesn't explain it. Oh
how,
wait, will this
how you
impact?
understand that it is E?
Because that's the only, I don't know that all of the other ones. Um, he did it. The researchers did it, but I don't think that will cause a problem with the conclusion. Like inclusion of exclusion of patients that use methadone only for detoxification. Okay, what is the issue there? I mean, there is no issue there. Okay, he didn't want to add this patient because they only use it for a short period of time. Makes sense.
Yes,
Exclusion of pregnant patients. We don't want to hurt the pregnant patients. Okay, makes sense. You exclude them. Inclusion of randomized controlled trials only. This is we know randomized controlled trials are the best ones, so it's the best ones that the best ones to use. So there's nothing wrong with it. Inclusion of trials that compare active drug with placebo. The randomized trials usually compare the new drug with the placebo, so there is nothing wrong with that. Use of urinalysis to determine treatment retention. That's what I was looking up here. He didn't use urinalysis for treatment retention. He used it to confirm that the patient was not using cocaine and
okay,
benzos and all these things. So the only thing that was left was inclusion of trials with intervention duration of 2 weeks. And I remember when you were reading, right here, it said that the duration of the study intervention ranged from 2 weeks to 52 weeks. But between 2 weeks and 52 weeks, a lot of things can happen. So I felt like 2 weeks was really short if you compare it to 52 weeks. That's why I kind of went with
okay.
it. Yeah. Let's see if he added something. Inclusion, whatever, right here. Buprenorphine and methadone are both, we already read on. Maintenance therapy for opioid use disorder often requires long-term treatment. Thus, a 2-week study does not reflect the real-world treatment scenario. Okay. For USMLE, understanding the limitations of study duration is key, especially for chronic conditions. Longer studies provide better insights. Opioid maintenance therapy is a prolonged treatment strategy, so any study duration less than what is clinically relevant can skew the results. Correlate the chronic nature of opioid use disorder with the need for longer trial durations to get meaningful conclusions. Remember that our trial design and duration can affect its results in its result generates whatever that word. Um, do you want me to read what the other options are wrong?
No.
Okay. Next.
Okay. Which of the following is most likely to bias the results of this study?
Oh, to bias. Okay. I have no idea. Source of funding. Bias the result of the study. Okay. Source of funding study government Department of Health. Where was the study conducted? Um, did not really say where, I guess.
Ready?
Yeah. Or is it E? Okay, whatever. DME. Wait, what was the answer? The likelihood publication bias. Wait. Okay, the ones that show positive results will be more biased and more likely to show that. This does not make any sense. What is the answer? Let me wait. Let me see on this one. C. Likelihood that more trials with positive results will be published. More trials with positive results will be published. The scenario highlights a study examining methadone versus buprenorphine and potential bias affecting the study results. For USMLE, publication bias is important. Studies um, with positive results are more likely to get published than those with negative or no results. Thus, the review may inadvertently overrepresent positive outcome if they primarily capture published studies. Publication bias skews systematic reviews because the positive results get more attention and are more likely to be published. For example, scenarios bias questions often hint a systemic issue in study collection or analysis.
Okay.
Okay, don't.
Let's take a break.
Okay.
My head is ringing after a 57-year-old man is brought to the a 57-year-old man is brought to the emergency department by ambulance 30 minutes after he has lost 30 minutes after he has loss of consciousness. His wife says that he was making dinner when he fell on the kitchen floor. He has hypertension and his only medication is lisinopril. He has no history of operative procedure and food. Temperature is 37.2 degrees Celsius. Pulse is 90 per minute. Respirations were 10 per minute and levered. Blood pressure 180 by 100 millimeter of mercury. Pulse oximetry on 40% oxygen by face mask showed oxygen saturation 99%. On arrival he is unresponsive. His GCS score is 3. He is intubated, mechanically ventilated. He is intubated, mechanically ventilated. Temperature is 99, pulse 90 per minute, ventilatory rate 10 per minute. Blood pressure 180 by 100 millimeter of mercury. Pulse oximetry on FiO 2.5 per oxygen saturation 98%. On examination, doll's eye oculocephalic movement shows absent eye movement, and the corneal reflex is absent on ice water caloric testing. There is no nystagmus or deviation of the eye toward the CT scan show rupture cerebral aneurysm. The wife is notified the patient's condition. She says he wanted to be an organ donor but does not have advanced directive. Which of the following is the most appropriate? Next.
Ready?
Wait,
Okay.
ready.
Okay. It is contact the organ bank for potential donation. His spouse already indicated what should be happening next. Advance directive won't matter when he's brain dead. Um, Let me see if somebody says contact organ. Okay, right here. For an unresponsive patient with brainstem findings consistent with brain death, organ donation can be considered. With a rupture of cerebral aneurysm and absent brainstem reflex, brain death is highly probable, making the patient potentially eligible for organ donation. And for USMLE, recognize that the absence of advance directive does not preclude organ donation if there is knowledgeable not if there is knowledge of the patient wishes and family agreement. A patient with signs of breast dysfunction and radiographic evidence significant for brain injury should raise suspicion of brain death. In organ donation scenarios, consider the clinical context and the patient's or surrogate decision makers express wishes. Okay, okay. It's not determined. No, what was the other one? This one. Lack of advance directive does not preclude organ donation, especially if the family or surrogate decision maker is aware of the patient wishes. Okay.
Okay, can you
Next.
give me 1 minute? I'm coming. 1 minute.
Yes. Yes. Okay.
Next question. A 36-year-old woman gravida to para 1, 39 gravida to para 1, 39 weeks of gestation, to the hospital, admitted to the hospital for admitted to the hospital in labor. She reports painful contraction that occur every 2 to 3 minutes and last 60 seconds. She has had vaginal bleeding. She has history of serious illness and pregnancy has been uncomplicated. Temperature 37, pulse 84 and regular blood pressure 110 by 70. The abdomen is non-tender and consistent in size with 39 weeks of gestation. External fetal monitoring show heart rate 150 per minute with moderate variability. Several spontaneous acceleration, no deceleration. An external tachometer shows regular uterine contraction. Every 2 to 3 minutes, the cervix is 6 centimeter dilated and 100% effaced. The vertex is zero station. Ultrasonography of the fetus show cephalic presentation. The membrane is artificially ruptured, yielding copious clear fluid 30 minutes after the cervix is 9 centimeter dilated. 100% effects. The vertex is 1 plus station. A fetal heart tracing is shown. Which of the following is the most appropriate? Uh, okay, ready?
Yeah, sorry. Is expected management. Does anything wrong here? Baby is doing well and mom is doing well. You are all good to go. It's not advising patient to begin pushing when the baby is about to come out. So you push when the baby is about to come out, I guess. Wait, I need to see if they said something different. Expecting management. Clinical scenario describes a woman in active labor with reassuring fetal heart rate. For ESMD, it's essential to recognize that there is no rush to expedite delivery in the absence of fetal distress or maternal indication. Reassuring fetal heart rate with good cervical progression in active labor suggests normal labor process. When there are no signs for fetal distress or fetal or maternal complication, allowing the labor to progress naturally is the best course of action. Advising the patient to begin pushing reserved for when the cervix is fully dilated, like 10 centimeters. Okay. Next.
A 27-year-old woman comes to the office because of 3-week history of nasal congestion, cough of productive sputum, intermittent moderate headache, intermittent moderate pain over cheeks. She has had similar symptoms three She has had similar symptoms 3 to 4 times yearly during the past years. The symptoms last 2 to 8 weeks and generally resolves spontaneously. She has had 2 weeks of bacterial pneumonia during the past year. Both episodes resolved with antibiotic therapy. Her only current medication is acetaminophen as needed for her. Vital signs are often Vital signs are within normal limit. Examination shows no abnormality. Serum study results decreased. IgA, IgG, IgM concentration. Antibiotic therapy is begun. The patient's condition improves. Which of the following is to decrease the likelihood of recurrent infection?
Ready?
1 second, please.
Okay.
Ready.
Okay. It's the monthly immune globulin replacement therapy. CVID shows up like age 20 to 40. The biggest thing to make note of, delay presentation and decreased IgGs, common bacterial infection but later in life. Um, you want me to read the other one? I feel like this
No.
one is really clear. Yeah. Okay.
The 37-year-old woman of man 37-year-old man comes to the office because of 2-year history of mild moderate fatigue. The fatigue waxes and wanes without relation to activity. He has no history of serious illness, takes no medication, he drinks 3 glasses of whiskey weekly. He has had 2 lifetime female partners. He uses condoms consistently. He immigrated to the US from China 15 years ago. Vital signs are within normal limit. Examination discloses no abnormality. Results of the lab studies are shown. Creatinine 1.2, ALT 85, AST 60, HbSAg positive, anti-HCV negative, anti-AGS negative, and IgG anti-HBC positive. Blood hematocrit 35%, hemoglobin 12, MCV 82%. Without current without his current condition, the patient is most likely to develop which of the following? Ready?
Mm, sure. It's a hepatocellular carcinoma. Knowing risk factors. Listen to the.
Podcast.
Okay, never mind. Patient has chronic Hep B, I guess. And then let's see if this one is something different. The laboratory findings indicate chronic Hep B infection, like the surface antigen is positive and the IgG is positive too. Oh, okay. That means chronic. The patient long-standing fatigue and liver enzyme elevation corroborate with liver pathology, likely secondary to Hep B. For USMA, recognize the chronic Hep B infection is a significant risk factor for hepatocellular carcinoma. Chronic hepatitis can present subtly with fatigue and elevated liver enzyme. Associate Hep B, especially in endemic regions like China, with the risk of hepatocellular carcinoma. It's not essential. Mixed trichomonoria most associated with Hep C and polyarthritis, though sometimes nodosa, though sometimes linked to Hep B, it is not a common. It's not as common as hepat, the cancer in this context. Okay, next.
Okay. A 10-day-old boy is brought to the office because of moderate right knee pain. He is in no distress medical history. He is remarkable for hemophilia A. Examination of the right knee shows warmth and swelling. There is pain with flexion, and range of motion is limited by pain and swelling. Which of the following is the most appropriate? Ready?
Yes, sure. Is factor 8 concentrate. Hemophilia is a factor 8. Huh? Hemophilia A is a factor 8. If you are deficient in factor 8, you should probably give factor 11. I wanted to know what is not the factor 8. Okay. The patient presents with a hematosis characteristic of hemophilia A caused by deficiency of factor A. Replacing the deficient factor is crucial to stop bleeding and prevent further joint damage. For USME, recognized factor A concentrate is the immediate treatment for bleeding episodes with hemophilia A. So immediate. When presented with patient having a history of hemophilia A and symptoms of joint bleeding, such as swelling, warm, limited, and suspect hematosis. Hemophilia A factor A deficiency, hemophilia B factor 9. Fresh chlorine environment contains all chlorine factors, but factor concentrates are preferred in hemophilia for precision and safety. Mm, okay, next.
A 72-year-old man comes to the clinic because of 3-week history of visual changes in his right eye. During this period, he has noticed that the lines of his daily crossword puzzle look curved and the blinds in his apartment appear wavy. He wears magnifying lenses for reading. He has not had pain in his right. He has not had pain in his eye. Photophobia. He has no history of trauma on examination. Visual acuity 20 by 200 in his right eye, 20 by 100 in his left eye. Both pupils are round and reactive to light. Palpation of both lobes through closed eyelids shows no abnormalities. There is normal red reflex bilateral. The lens appear the lens appear clear. Which of the following is the most likely diagnosis? Red. Oh, sorry, I'm not ready yet.
Okay.
Okay, ready.
So it is macular degeneration. Straight lines appearing curved is a classic vignette. Wavy lines in an old person is macular degeneration unless proven otherwise. Um, Let me see if this one says something different. The patient presentation highly suggests macular degeneration, specifically age-related degeneration. The macula, the central part of the retina, is responsible for central vision. Degeneration can cause lines to appear curved. USMLE recognized that age-related macular degeneration (AMD) frequently presents with metamorphosia, warped vision without pain. Elderly, like all men, with changes in central vision, especially with distortion like wavy lines, should prompt consideration of AMD. Remember, AMD affects central vision, so tasks like reading or detailed work may become more difficult. Okay, next.
In macular degeneration, there is drusen body, isn't it? Am I right?
Immaculate. I don't.
The
I don't
drusen
do that.
deposition, the dry and the wet, like in age-related macular degeneration, there is drusen body.
I'm not sure. Let me check on macular degeneration. Where is
Dry
it?
for drusen.
Did I pass it?
Sorry.
Oh, I'm saying, did I pass the macular degeneration? Because I don't see it here. Never mind. I guess they don't have it here. Degeneration. Hmm. No, they don't have it here.
Okay.
But I don't remember if the
Okay.
Drusen bodies
Le- leave it.
was in the yeah. Hmm.
Okay. Can
Yeah,
you remember the painful and painless vision loss? That is very confusing for me.
what do you mean? The
Like there are some causes of painless vision loss. There are some causes of painful vision loss,
I don't
like
remember. I
central
think
retinal artery occlusion, vein occlusion. On
if
that
you
perspective, sorry.
like, I cannot. If you tell me one like central retinal, I know that's painless, but I cannot tell you all the painless causes and all the like. If I,
Oh,
if you tell me
yes,
one, I
yes.
can
Okay.
tell you. Yeah, I can tell you if it's painless or painful. Mm, that's weird. Okay, they don't have macular degeneration like a specific thing for that here. Okay.
Okay. A 28-year-old man who comes to the clinic because of today's history of red velvety, red, severely painful lesion on his forearm. He says that he felt stinging pain as he put his shirt on, at his put his shirt on in the dark 2 days ago. The pain was so severe, he immediately threw down the shirt and saw a spider running across the floor. He returned yesterday from a week trip to the mountains in the southeastern US. He has type 1 diabetes, mellitus, treated with lisinopril and insulin. He does not drink alcoholic beverage. He is sexually active with two male partners and uses condoms inconsistently. Vital signs are within normal limit. A photograph of the lesion is shown. No other abnormalities is noted. Which of the following physical findings is most likely to appear during the next 24 hours?
Hmm, okay, spider bite. I don't know.
Okay, ready?
Okay.
Is it fasciitis like that necrotizing fasciitis? Okay, let's see.
Yeah, you went too far. I thought it was just a spider bite. Okay, okay.
Okay, you
The
are
the
right. Areas of Ishkar at the center. It's a spider bite.
Yeah, no, but but I didn't get the question. Is that what you were asking? I thought,
I
were you
think that as there is a, I think that it may be necrotizing fasciitis. Maybe
from
due
what?
to spider bite can cause neck fash.
Oh, okay, okay, yeah, okay, now I get it. Okay, you thought the spider bite caused the okay, yeah. Areas of the answer is areas of eschar at the center of the wound site, more likely from the brown recluse due to the location. Okay, you have to know the location here. Go for the localized symptoms. The others are way too aggressive. It essentially ends up healing over weeks. All we care about right now is the fact that the patient was bitten by a spider. Don't apply too much brain power. Just read the question and learn and utilize the story behind the answers. So for spider bite from the brown recluse, the lobster, whatever, is south midwestern U.S. In dry warm areas like the attics and basements of the house. Spider identification is rare. Usually, the initial bite is painless. Um, okay, small red papule that self-resolve is most common, but it can also be burning pain, blister, and then a burning pain, then a blister, then it becomes necrotic like a scar. Expands over days, heals over weeks. Systemic loso, the brown recluse, whatever, losocedism, the systemic disease. Fever, hemolysis, and DIC is uncommon. Management, clean wound, apply ice, no debridement until lesion has stopped growing. Supportive management for systemic infection and updated tetanus. It's not okay. I have that. I guess I have to read the other one. Areas of a scar. Okay, the patient presentation should have a bite from the spider, which can lead to necrotic, whatever, arachne. The characteristic development of an scar at the center of the wound site often follows the initial reaction and represents tissue necrosis. For USMLE, recognize that brown recluse spider bites can lead to local tissue necrosis due to venom from enzymes. Due to venom's enzymes, yeah. In the context of suspected spider bite in region, no. From the presence of brown recluse spider, expect the progression of block and skin changes, including the development of an scar. Focus on the location and characteristic evolution of the bite site when considering brown recluse spider. It's not gangrene at the distal aspect. While tissue necrosis can occur, it's typically localized. It's not edema. This will indicate a more systemic reaction of a significant infection. and is not rapidly spreading erythema. This suggests bacterial cellulitis or a more aggressive infection. Okay, next.
Okay. In 37, a 37-year-old man comes to the clinic for a health maintenance examination prior to any plan. He feels well. He has no history of serious illness, takes no medication 1 year ago. His blood pressure is 136 by 85. He is 173 centimeter 5 feet 8 inch tall, weight 100 kg, BMI 33 kg per meter square. Today his blood pressure is 138 by 87. Examination should no abnormality. In addition to recommending weight loss, which is the most probable to prevent cardiovascular morbidity.
Hmm, we start with ACE. Do we do the dash diet? What's appropriate next step? Oops. Uh,
Ready?
mm, Not really. We start with the dash diet or we do ACE? Okay, ready. What was this then? This one? No, this one. It is dash diet. Looking at the options, does the patient really have hypertension? Not really. You need multiple readings to establish diagnosis of hypertension. So we can't really diagnose with hypertension. The management of hypertension first look for lifestyle modification, weight loss, and the DASH diet. When to look for at hypertension management when systolic blood pressure is 140 and more, and it's between 130 to 140. People with like chronic heart failure or CKD. Okay, got it. Let me see. Let me see if this is something different here. Dash diet. Okay. The patient's elevated BP points towards stage 1 hypertension. Lifestyle interventions such as dash diet are the first step. Weight loss can reduce blood pressure, and dash diet can amplify this beneficial effect. For USME, recognize a dash diet which emphasizes fruit, vegetable, whole grains, poultry, blah blah. Low fat dairy has been shown to reduce BP and should be advised before drug therapy in mild cases. Elevated BP pressure without end organ damage or other cardiovascular risk factors is initially managed with lifestyle intervention. On USMLE, lifestyle modification recommendation often precede drug therapy unless there is a compelling indication. ACE inhibitor therapy medication are typically reserved for stage 2 or 1 hypertension with evidence of end organ damage or other cardiovascular risk factor. Got it. Next.
A, third, a 39-year-old man comes to the a 39-year-old man comes to the office because of 6 week history of mild fatigue and increased thirst and urination. During this time, he also had a 6.8 kg. He also had a 6.8 kg weight loss despite no change in appetite. He is otherwise asymptomatic. He has no history of serious illness, takes no medication. He has no history of serious illness, takes no medication. He is 180 centimeter tall, weight is 61 kg, BMI 19 kg per meter square, temperature is 37 degrees Celsius, pulse is 80 per minute, respiration 18 per minute. blood pressure 118 by 70 millimeter of mercury. Examination showed no abnormality. Results of the lab showed sodium 135, potassium 4.2, chloride 100, urea nitrogen 25, glucose 5.7, glucose 578, and HbA1c is of 10.7%. Which of the in addition to recommending diet and modification is the most appropriate step? Ready?
Sure. Let's see. It is insulin therapy. Serum glucose 578 and A, A1C is 10.7. Most likely type 1, which is typically managed by insulin. None of the oral farm is indicated right now for that. And I think this one is pretty clear. Want me to read the other one?
No, no.
Okay.
2 days after admission to the hospital for a treatment of a fractured femur and closed head injury sustained in a motor vehicle collision, a, an 8-year-old girl has brief generalized tonic-clonic syndrome. CT scan of the abdomen. CT scan of the head showed CT scan of the head on admission disclosed no abnormality. He has no history of serious illness. Oral acetaminophen was initiated for pain. The patient underwent open reduction and internal fixation for fracture. Open reduction and internal fixation for fracture. She received no routine medication. Today she appears drowsy but responds to questions appropriately. She is at 55 percentile for height, 55 percentile for height and weight, and BMI. Temperature is 36.8. Pulse is 92 per minute. Respiration 24 per minute. Blood pressure 106 by 64. Pulse oximeter on Bromia show oxygen saturation 95%. Pupils are equal and reactive to light and accommodation. Ocular movements are full. Muscle strength is 5 by 5. The tendon reflex are normal. Serums results of the serum studies are sodium 122, potassium 3.8, chloride 94, bicarbonate 24, calcium 8.8, glucose 80. Which of the following is the most appropriate next?
I don't know. This one. Mm,
Ready?
No. Between A and D. Initiate therapy with point 0.9 saline. Would I give intrabolus? Unless you give intrabolus. I don't know. Okay, ready. Oh, wrong one. It is administered bolus of IV 3% saline. The sodium is very low. This person has symptomatic hyponatremia with seizure. This scenario is where hypertonic saline is indicated. It's not initiate therapy with, oh, it doesn't say why not here. Anyway, let me. Let me find the other one. Administer Boros.
For
Administer Boros. Where was it? Did you find it? Right here. The patient symptoms of seizure and serum studies of hyponatremia that's less than 125. Rapid correction with hypertonic saline is essential when symptoms are severe, especially when they include seizures. But you simply remember that the severe symptomatic hyponatremia necessitates immediate treatment to prevent irreversible neurologic damage. Severe hyponatremia can cause non-specific symptoms like nausea, malaise, headache, progressing to seizure, coma, brain herniation, and acute. Always correlate the clinical picture with life finding. In this case, the low serum sodium combined with the recent seizure. It's not saline, 0.9% saline. Isotonic saline might not raise sodium levels quick enough for symptomatic hyponatremia. Okay, next.
a 43-year-old man, a 43-year-old man comes to the office because of 2 week history of fatigue and mild pain in his right armpit. He has not had fever or weight loss. Medical history is remarkable for type 2 diabetes mellitus, hypercholesterolemia. Medications are metformin, simvastatin, aspirin. She is a social worker and frequently visits clients in a homeless shelter. She lives alone with two dogs and a cat and has one male sexual partner. Vital signs are within normal level. She appears well. Examination of the right upper extremity shows an erythematous axilla with a 4 centimeter mobile non-tender non-fluctuant mobile tender non-fluctuant axillary lymph node and a tender 1 centimeter epitrochlear lymph node. Evidence like examination shows no epidemic. Which of the following is the most likely diagnosis? Ready?
One moment. Hmm, ready. So it is scratch disease, Bartonella Hensley, um, painful lymphadenopathy, painful lymphadenopathy. That's what it says. Patient has pain in his armpits and has type 2 diabetes. Vitals are fine, but has tender lymphadenopathy. Castleman syndrome is mobile generalized lymphadenopathy associated with HHV. What's HHV? Like
Kaposi.
the Kaposi. So general lymphadenopathy and Kaposi is Castleman disease. Let's see if they say something else in the other one. Cat, no, cats, yeah, right here. Presence of tender regional lymphadenopathy, axilla and petechial in a patient with recent contact with cats points to cat disease. So you just merely remember that Bartonella Hensel infection is often associated with cat scratches or bites. Um, cat disease commonly presents with localized lymphadenopathy and a history of cat contact, particularly with kittens. Consider it, especially when the clinical picture does not suggest a more aggressive systemic disease like fever or weight loss. Asthma disease presents with systemic symptoms like with presents with systemic symptoms with lymphadenopathy. So systemic symptoms, lymphadenopathy and Kaposi. Okay, next.
Yes. A 2-year-old girl is brought to the office. A 2-year-old girl is brought to the office by her parents for a well child examination. She was adopted 2 months ago. She has no history of serious illness. and receive no medication. Vital signs are within normal limit. Examination shows no abnormality. After the examination, the patient asks where they should tell their doctor about the adoption. Which of the following is the most appropriate advice regarding this? Okay.
Ready?
Okay.
Um, the answer is as early as possible, even if she cannot process the whole experience. Logical reasoning. There is nothing special about kindergarten. Okay, let's find another explanation.
The
Um,
2-year-old girl did not understand anything.
yeah, that's why I want to find the other explanation. As
This is
the-
crazy.
I was like, that's why I want to find the other explanation because this doesn't. Okay. Uh, okay, it doesn't say. I cannot find it. That question. What was the question again? As early as possible. Yeah, 2-year-old girl. Did you find it?
Wait.
2-year-old girl.
Yes. Oh
Okay.
no. Wait.
Mm,
Yes, yes, I found it.
okay.
It is page 65, question 106. Okay. Write question 106, then you will find.
Like question 106. Okay.
Okay.
As early as possible, everybody. Discussing adoption openly from an early age promotes trust and understanding between the child and the adoptive parent. It allows the child to integrate the concept of adoption into their self identity gradually. Parents can start the conversation early to ensure the child learns about their adoption in a supporting and loving environment. Transparency and openness in the families about adoption prevent feelings of betrayal and mistrust as the child grows up. Recognize that the developmental understanding of adoption evolves and discussions will be adjusted according to age. Even if not fully understood, early discussion laid the groundwork for more complex conversation as the child matures. It's not once the seal on the adoption record has been lifted. Telling is not necessarily tied to bureaucratic process. Right before she's enrolled into kindergarten, this is arbitrary time that might delay the conversation unnecessarily. When she learns that she's not biologically related to her parent, waiting for this realization can lead to confusion and emotional turmoil. Okay, you got it?
Yes.
Okay, next.
But even that doesn't make sense. Okay,
Yeah, I mean, in real life, I'm pretty sure, like, yeah, you won't do that. It doesn't really make sense. Mm,
sorry.
maybe, because I have my.
If you tell the 2-year-old baby that what will happen, nothing will happen. He will not gonna understand.
No, it's not about telling, but it's not about them understanding. It's about because like my mom and her little sister was studying abroad in another country, and she got pregnant,
Okay.
and she wanted to keep studying. So
Okay.
the baby was like 1 month old, and she came and gave the baby to my mom. So my mom raised the baby like he was like I didn't even know he wasn't my sibling until because yeah, he had our same last name. He was raised with us, and I was little when she came and dropped the baby. The baby was 1 month, and he grew up with us, and I call him my brother because
Okay.
technically he's my brother, But I don't
Yes. Yes.
even. But he always knew. I don't even remember because I was also young. But he always knew that his mom was abroad studying, and he would talk to her all the time. To her all the time. I don't even remember when he started talking, but he always knew. He always knew he had two moms, my mom and his mom. All the mom was abroad, and he was. So I don't know, but so it made it less awkward. Like it wasn't weird. Like he called
E-
my mom mom and he called his mom mom. But we
Okay,
call my I call my mom mom and I call his mom auntie. So you see, I don't know. I guess he just made
but
it.
the good thing is your mom didn't tell you, like it, like own brother and others brother. We actually feel like mentally we feel the difference. You got my point. What I'm trying
I
to say.
don't. I never asked him if he felt. I don't know. I wonder if he felt the difference as we were growing up. I never asked him if he
Okay,
felt different. I don't know. I wonder, but yeah, I feel like yeah. I guess it's better. I don't know if my mom sat him down and had a conversation. You have another mom. I never. I don't know because I was also. But he always talked to his mom. He always talked. Called my mom. You know, mom. Call his mom. Mom.
so he
Yeah.
he got the thing, but you
He got
haven't.
the Yeah, he got the idea, but I don't know at what age he got, because
Okay,
yeah. So I think it's yeah, maybe yeah, just start telling the kid. I don't even know when he understood what was happening. I don't even.
but
I
I
wonder.
I think that your mom didn't tell him at 2 years of age.
I think,
You can
oh,
ask her. You
I'm
can
gonna,
ask her.
I'm gonna ask him. Like, did mom sat you down and told you something?
When she sat him down and told him the whole story.
I don't know. I don't even know if she did it. Maybe she never did. She never do it, and he just. I don't even know. I don't even know how that works.
It is not possible because
Yeah, I don't
if
even know.
the deep discussion didn't happen, because the kid who raised like your brother raised with you, so he is very comfortable with you guys and your mom, and he actually thought that this is her own mom. So when he has heard this, he may be in shock, or
Maybe,
it take time to process.
maybe my aunt told him. I don't know. I really never figured out how that went. I don't know. Maybe his own mom told him when he was because they always talk. Even always as long as I remember, they've always talk. He always talked to his mom on the phone, and when we started having video call, he will video call his mom all the time. So I don't know when how he. I'm gonna ask him. Now that I'm saying, just it never
Okay,
came to my mind. Yeah.
yes.
Hmm. Anyway.
A surgical ICU observes the number of the days that patients have central venous catheter patient have central venous catheter in place, and the number of the bloodstream infection have been increasing. A multidisciplinary team from the unit would like to decrease the number of the days the central venous catheter are in place in order to improve performance in this area. Which of the following is the most appropriate next step? Decrease the-
Jeez. Increase the number of days. Hmm. To identify what they believe to be the muscular pattern to normal. Hmm. Oh, these stickers on my ICU doors reminding staff to assist in it. Central line. That's, mm, between A and C. I feel like it's A. Ready?
Yes.
Probably it's A. A. Ask clinical providers in the unit to identify what they believe to be the most common factor leading to non-removal of CVCs. Uh, the principle, the principle doing things in order. They know they have a problem. We want to decrease the number. Makes sense to try to figure out why there is a problem. So PDSA, but more in regards of conceptual. Okay, this does not make sense. Let's try to find another explanation. Ask the what's the thing? Ask clinical providers. Providers.
Question 41.
Yeah. The first step in quality improvement is to understand the root cause of a problem. Engaging healthcare providers in identifying barriers help develop effective strategies to address the problem. For USMLE, understand that clinical providers work directly with the patient will have a first-hand knowledge about real-world issues and barrier to catheter removal. CVCs can increase the risk of closing infection when they remain in place for a long time. Situations involving quality improvement always identify root cause before implementing changes. Root cause. And placing stickers may not address specific reasons for prolonged catheter placement. So let us find the cause before implementing the change. Okay. Next.
A 17-year-old girl is brought. A 17-year-old girl comes to the office because of 3-month history of daily moderate epigastric pain that is more severe after meals. 3 weeks ago, she had watery diarrhea for 2 days, which resolved spontaneously. She has not had vomiting. She has no history of serious illness. Take no medication. Vital signs will be normal. Examination, including abdominal examination, shows no abnormal activity. The following is the most likely to confirm the diagnosis.
3 months of moderate epigastric pain. It's more severe after meals. Hmm. Mm, ready?
One moment, please.
Okay.
Ready?
Mhm. This endoscopy treat will triple or quadruple therapy. I guess she has H. pylori. Patient with chronic epigastric pain more severe after meals, more severe after gastric acid secretion in the stomach, pancreatic pancreas area. Patient is young with no history of alcohol, so more stomach issues, more like PUD, which is PUD ulcer this peptic ulcer disease. Okay, did not see that one coming. Let me see if I can endoscopy. This one. This thing, epigastric pain was by meals without any alarming feature like weight loss, anemia, whatever. Suggests peptic ulcer disease or gastritis. USMLE is crucial to understand endoscopy is the best diagnostic modality to visualize and biopsy gastric mucosa to identify this condition. Consider peptic ulcer disease or gastritis in patients with meal-associated epigastric pain. Oh, meal-associated epigastric pain, especially when they do not have systemic symptoms. For USME, remember endoscopy as the go-to diagnostic tool. Is not CT scan more useful for assessing structural abnormality of masses? So I guess not over and parasite, useful for suspected parasitic infection, and stool culture for bacterial GI infections. Okay, next.
A 23-year-old man comes to the emergency department because of 1 hour history of intermittent cough spasm that began suddenly while he was attempting to clean molds from his garage with a mixture of acetic acid and cleaning agent. The cough is non-productive. He reports shortness of breath only during the coughing spasm. Medical history is unremarkable. He takes no medication. He does not smoke cigarettes or drink beverages or use other substances. He is 180 centimeter tall and weighs 75 kg. BMI 23 kg per meter, vital signs within normal. Pulse oximeter on room air oxygen saturation is 94%. The patient has periodic paroxysmal coughing during the examination. Oropharynx is clear. Auscultation of the lungs discloses bilateral wheezes through all lung fills. There is no use of accessory muscles of respiration. The remainder of the examination, the remainder of the physical examination discloses no abnormality. Chest X-ray shows mild hyperexpansion of the lungs. Bilateral results of the arterial blood vessel analysis on room air shows PO2 72, PCO2 38, pH 7.41, bicarbonate 23. Which of the following is the most appropriate initial step in the management?
Ready?
1 minute, please.
Mhm.
Ready.
Okay, so it's albuterol therapy. Young person who's fairly healthy with wheezing and coughing, ABG is normal. He has asthma exacerbation. Methylprednisolone therapy within the first hour if the person is not responding to like beta agonist, then consider IV steroids, then magnesium. Let's see if this is something different here. The patient symptoms coughing spasm, wheezing, shortness of breath after cleaning with chemicals suggests a reactive airway event or chemical-induced bronchospasm. Albuterol short beta agonist provides rapid bronchodilation, making it first line for acute bronchospasm. For USME, I always associate sudden onset wheezing following exposure to irritants and allergen with bronchospasm. And remember that the first line is bronchodilators like albuterol. Chemical exposures, especially in a confined space like a rash, can lead to inhalation injury, manifesting as cough and wheezing. Given the acute onset after non-exposure and the physical exam findings, diagnosis likely bronchospasm. Bronchoscopy is not indicated at first line. Intubation, the patient is not in severe respiratory disease, so distress. So this invasive step is not needed. Methylprednisolone, not the first line immediate treatment for acute bronchospasm. Mm, can we stop here today?
Yes, yes, obviously. You have to
Sure.
go. I know.
Yes. I'll see you tomorrow.